Hello, my name is Martin and I'm an internal medical trainee working in South London. Let's talk about COVID-19 and some of the complications arising from it. We'll cover some epidemiology and talk about the transmission of the virus. We'll discuss risk factors for contracting COVID and increasing the severity of the disease. We'll discuss some of the challenges around diagnosing COVID-19 and how to investigate a patient with suspected COVID. We'll move on to the complications we're seeing in patients admitted to hospital with COVID. And finally, a little on how to manage these patients. So first, a little bit of background. Like MERS and SARS before it, COVID-19 is a coronavirus. It was first identified when clusters of patients with an unknown severe respiratory illness were noticed in Wuhan in China, and COVID-19, the virus, was identified in the bronchoalveolar lavage samples of these patients with this nasty pneumonia. Some information about transmission of the disease. So this is primarily from symptomatic people via respiratory droplets, by contact with contaminated objects or surfaces, or by direct contact with infected people. There is no evidence of vertical transmission, fecal-oral transmission, or sexual transmission, but the virus is detected in virtually every bodily fluid that can be tested. There's been a lot of talk about the R value, especially in the UK, with it being the government's flagship marker of progress in controlling the pandemic. And R0 is the basic reproductive number, which translates to the expected number of people one case will have transmitted an infection to, in a population where everyone is susceptible. The R0 of COVID-19 is estimated to be somewhere between 2.2 and 3.3, meaning every infected person will pass the virus on to between roughly 2 and 3 people. In the UK, a study of 20,000 COVID-19 patients admitted to hospital showed that the median age of these patients was 73. Less than 5% of the confirmed cases have been in children. And of note, a UK study in March 2020 screened 1,600 clinical and non-clinical staff, and 14% of these staff members, all working in a Newcastle hospital, tested positive for COVID-19. I think it's important to mention the most common and significant risk factors for a more severe disease course, in part because of the role they play in many of the complications we have been seeing in COVID-19 patients. Firstly, we have age. In a US study, patients aged over 65 made up 45% of hospitalizations, 53% of ICU admissions, and 80% of deaths. We know patients who are overweight and obese do worse in both a ward setting and when intubated and ventilated in critical care. Anecdotally speaking, virtually every patient under 65 that I have seen need ICU admission has been obese. There is also an increased risk of having a positive test, although this may be due to an increased likelihood of presenting unwell and being tested in the first place, as community testing has been limited in the UK. Other risk factors include being a nursing or residential home resident, male sex, BAME patients. Lancet study in May 2016 showed the adjusted odds of a positive test was 62% in black people compared to 15% of white people. Some comorbidities that are particularly important: hypertension, cardiovascular disease, diabetes, underlying respiratory disease, malignancy or kidney disease, being a smoker, and lastly travel. So initially travel was a vital screening question when we were assessing patients, to the degree that we changed our medical referrals list to include a mandatory column for travel history. Since lockdown in the UK, this has become virtually irrelevant, with very few people travelling abroad and few countries having a higher prevalence of COVID-19 than the UK anyway. This will become more important, as has been seen in countries such as New Zealand recently, when tracking cases and contact tracing becomes more established. I'm not aware of any evidence that there is variation in the severity of the disease based on where it is caught, but this may be established as a risk going forward. So let's talk about investigations. PCR from respiratory, nasal and pharyngeal swabs are currently the most practical way to diagnose COVID-19 infection. It's limited by low sensitivity, however. Commonly, patients who you are highly suspicious of can have multiple negative swabs. So what leads you to being highly suspicious if no test confirms COVID-19 positive on the screen? Firstly, symptoms. So classically a dry cough, fever, shortness of breath, flu-like symptoms, diarrhea or abdominal pain. Patients will present hypoxic and commonly in type 1 respiratory failure, which we'll cover more detail later. On blood tests, you'll classically see a low lymphocyte count, high troponin T and D dimer, deranged liver function, the patient will probably have an acute kidney injury and they'll have a raised CRP. X-ray and CT appearance we'll cover later, but there are some classical pictures there. We've spoken about PCR, but antibody testing is becoming more important. 2 respiratory consultants at my trust who were unwell with breathlessness and fever and had positive swabs for COVID-19 have actually had negative antibody tests. We don't know what this means. Does this mean they don't have antibodies, or does it mean the test is not sensitive enough? The test, regardless, takes several weeks for the patient to develop antibodies, and it's not that useful for testing current inpatients. However, many people do stay admitted to hospital for 40, 50 or 60 days, at which point it might be useful to categorically say whether or not they had COVID infection earlier in the admission. Let's talk about some of the complications. So initially, and probably most importantly, we have respiratory failure. So patients present with profound hypoxia. They're usually in type 1 respiratory failure and typically have a rising oxygen requirement over the first 24 to 48 hours of admission. What does this mean? Well, a PO2 less than 8 on an arterial blood gas. Patients often being on a 15-litre non-rebreathe mask, but with a normal or low PCO2. It is not uncommon to see alert and conversing patients with peripheral oxygen saturations in the 60s or 70s. These saturations in other diseases would not be tolerated, and the patient would be in severe respiratory distress, unconscious, or peri-arrest. Patients can be very tachypneic. We have had patients with respiratory rates for 50 to 60 breaths per minute for several days, with some recovering after this and some requiring intubation. They are often not breathless, and commonly only breathless on exertion. It has been reported that up to 8% of COVID-19 patients develop respiratory failure, and it is the leading cause of mortality in these patients. Let's look at some classical X-rays from COVID-19 patients. Here we can see an intubated patient. Note the endotracheal tube in the airway. The patient also has an NG tube and a right internal jugular vas cath or central line, and ECG leads over the chest. The obvious abnormality is widespread patchy consolidation bilaterally, preferentially affecting the peripheries. This peripheral patchy consolidation is also seen in this X-ray. And again in this X-ray here. Note the stenotomy wires without evidence of a prosthetic valve, suggesting the patient has had coronary artery bypass grafting. Having coronary artery disease, as we know, increases the risk of a severe COVID-19 infection. You can also see bilateral peripheral consolidation on this CT scan of a COVID-19 patient. Imagine you are standing at the foot of the patient looking up through their body. We are midway through the lungs here. There are also small bilateral pleural effusions. There's more widespread bilateral consolidation here, and even worse here. COVID-19 patients who have gone for autopsy have been found to have widespread alveolar damage, with congested capillaries due to microscopic thrombi. There is evidence of significant endothelial damage. There is also evidence of angiogenesis alongside alveolar hemorrhage. Let's talk about some options for oxygen delivery because it is important to understand these and what they mean for patients. Nasal cannulae are a well-tolerated form of delivering anywhere up to 6 to 8 litres of oxygen. Patients entrain oxygen when they breathe in as a reservoir of oxygen is created in the nasal cavity. This, along with most other forms of oxygen delivery, can dry out the patient's mouth and airways, and humidified oxygen is often better tolerated. Oxygen is delivered via a humidifier, but the percentage of delivered oxygen is limited by this. The next step up is a non-rebreathe mask. This has a reservoir bag which fills with oxygen that the patient will breathe from. This allows delivery of 15 litres of oxygen per minute, allowing an FiO2 or fraction of inspired oxygen of 60% plus. During April, our respiratory ward was cohorted with every patient on a 15-litre non-rebreathe mask who was for escalation to ITU if they required it, going to that ward. This massively outstripped the capacity the ward had to deliver oxygen, and we ended up rapidly relocating to a different part of the hospital with a better oxygen supply. In some patients, it is important you tightly control the FiO2. A Venturi mask allows you to do this. There are a number of coloured masks, each designed to take a predetermined flow of oxygen from the wall in order to deliver a carefully controlled FiO2. This is particularly important in patients with type 2 respiratory failure. I always remember type 2 respiratory failure as there being two things wrong, both a low PaO2 but also a high PCO2. This is less common in COVID-19 patients, but is common in patients with COPD or other airways disease, or restrictive defects that limit their ventilation. As I'm sure you already know, there are two processes which contribute to this roughly evenly. The first well-known effect is the loss of hypoxic drive. People without airways disease breathe in response to a rising PCO2. Patients who are chronically hypercapnic lose the drive to breathe in response to a rising PCO2, and therefore breathe in response to hypoxia. If you provide them with too much inspired oxygen, they reduce their respiratory rate and tidal volume, thereby blowing off less CO2. The second, and equally important factor, is that such patients will often have diseased, poorly ventilated areas of lung, perhaps emphysematous or bronchiectatic. Chronically, the blood vessels supplying these areas will vasoconstrict to avoid a ventilation-perfusion mismatch. This would be where too much blood is flowing through the lung that's not well ventilated. If you fill these areas of lung with a high percentage of oxygen, the patient's PO2 will rise, but they will also lose that adaptive vasoconstriction in those regions of the lung. This will lead to more blood flow through oxygen-rich but poorly ventilated areas of lung. This will cause a mismatch and lead to the PCO2 rising as it is shunted through the lung without being ventilated and breathed away. Non-invasive ventilation, sometimes referred to as BiPAP, is a way of treating type 2 respiratory failure. By applying a tight-fitting mask and varying the pressures between a patient breathing in and breathing out, you assist the patient to ventilate their lungs and clear that CO2. Now back to COVID. In patients who are persistently hypoxic, despite receiving 15 litres of oxygen, the maximum that can be delivered from the wall, via a non-rebreathe mask, the next step is intubation and ventilation, to allow a higher fraction of inspired oxygen to be delivered, as well as positive airways pressure to assist with oxygenating the patient. Now, high-flow nasal cannulae, often referred to Optiflow, is a method of delivering between 60 litres of oxygen per minute at 60 to 80% fraction of inspired oxygen. It is often used to treat severe type 1 respiratory failure and avoid the need for intubation, but it's an aerosol generating procedure, and it's largely been avoided in the context of COVID-19 for fears of infecting staff members and other people in the hospital. Now, virtually every patient admitted to hospital with COVID-19 symptoms will end up being treated for a concurrent bacterial infection. It can be difficult to distinguish between COVID-19 and a community-acquired pneumonia, as they can both present with fever, shortness of breath, consolidation on a chest x-ray, and rising inflammatory markers. These can be confirmed with sputum cultures, blood cultures, or from a response to antibiotic therapy. Unilateral consolidation on a chest x-ray, particularly if it occupies one discrete lobe in the lung, is far more likely to be bacterial in nature. Patients with COVID-19 are significantly more likely to develop pulmonary emboli and deep vein thromboses. Studies have reported that between 20 and 46% of patients in the intensive care unit with COVID-19 are found to have DVTs or PEs. And in one study, evidence of deep vein thrombosis was found in 58% of patients who had gone through autopsy, in whom no VT was expected prior to their death. Assessment for PE and DVT is complicated by the similarities in presentations of PEs and COVID-19. Patients with COVID-19 present with significant hypoxia, shortness of breath, tachypnea, and tachycardia. They often have D-dimers in the thousands and troponins in the hundreds. These are all also hallmarks of pulmonary embolus. Pulmonary emboli can also present with fever, with chest x-ray changes, and even without chest pain. It is important, therefore, to have a low threshold to investigate COVID-19 patients for PEs. There is evidence to show that the higher the D-dimer, the higher the risk. Therefore, a D-dimer in the thousands in an unwell patient with COVID-19 should prompt the team to at least consider performing a CTPA, especially in the context of type 1 respiratory failure. Patients with confirmed PE should be anticoagulated for 3 months. There is not yet a consensus on increasing the doses of prophylactic low molecular weight heparin when patients are admitted to hospital. Some trusts have altered their guidelines. Additionally, some trusts are routinely prescribing anticoagulation in the form of a direct oral anticoagulation therapy such as rivaroxaban or apixaban or heparin for patients with proven or highly suspicious for COVID-19, even in the absence of PE or DVT. On this CT scan, you can see bilateral pulmonary emboli. So again, we're stood at the foot of the patient looking up. You can see across the pulmonary arteries here a filling defect on both sides. Moving on to cardiac complications. So COVID-19 patients have presented with myocarditis, with heart failure, arrhythmias, and acute coronary syndrome. Somewhere between 7 and 20% of hospitalized COVID-19 patients have evidence of myocardial injury, as demonstrated by a rising troponin. This is a poor prognostic factor, increasing the risk of a patient needing intensive care admission, of needing intubation, and ultimately correlates with a higher mortality rate amongst these patients. Some patients present with chest pain and with troponins hundreds of times higher than the upper limit of normal. These patients may undergo urgent angiography, only to be found to have pristine coronary arteries and no evidence of plaque rupture or coronary stenosis. Other patients present with peripheral and pulmonary edema. An echocardiogram demonstrates new presentations of heart failure, with reduced ejection fraction and ventricular impairment. It is unclear whether these cardiac abnormalities will persist beyond the course of their acute COVID-19 illness. Acute kidney injury. So there's evidence from the US that shows somewhere between 36 and 78% of COVID-19 inpatients will develop an acute kidney injury. 90% of patients who are intubated for COVID-19 develop an AKI. And 31% of intubated patients go on to require renal replacement therapy, usually in the form of hemofiltration in ITU. Needing renal replacement therapy due to an acute illness has a significant impact, not just on increasing mortality, but on the risk of developing chronic kidney disease and ultimately progressing to end-stage renal failure. The pathophysiology for these AKIs includes hypotension and hypovolemia, causing tubular injury, thromboses affecting the kidney, rhabdomyolysis. It is important to treat these AKIs as you normally would, so we would stop nephrotoxic drugs such as non-steroidals or ACE inhibitors. Initially, back in March and April, there was a consensus that giving diuretics to offload fluid from these patients in order to help gas exchange in the lungs and reduce inflammation was useful. We now know that unless otherwise indicated, it is better to fluid resuscitate dehydrated patients and keep these patients euvolemic, aiming for a neutral fluid balance. Excluding other causes of AKI, such as urinary tract obstruction, is also important. It's common for patients to present with deranged liver function tests when they present with COVID-19. Raised transaminases have been reported in up to 50% of inpatients. This tends to be a self-limiting problem. Patients do not tend to progress to fulminant liver failure, do not tend to develop encephalopathy, ascites, or jaundice, the three things that would mark decompensated liver disease. Having abnormal liver function on presentation is, however, a poor prognostic marker. Moving on to management. Until the past week, management of COVID-19 has been entirely supportive. It involves keeping the patient alive, maintaining their oxygenation, giving fluids or diuretics as required, providing renal replacement therapy if needed, and waiting for the patient to recover. This past week, evidence from the ongoing recovery trial has shown dexamethasone, at a dose of 6 mg per day for 10 days, reduced deaths in ventilated patients by 1/3. It reduced deaths in COVID-19 patients requiring oxygen therapy but not intubated by 20%. Based on this early analysis, the national guidance has changed and now advises all patients requiring hospital admission be given dexamethasone. This does not apply to COVID-19 patients in the community who are not admitted to hospital. We currently have a single COVID-19 positive patient in our hospital, and they were started on dexamethasone on Tuesday. In summary, we have covered some background and epidemiology, common and significant risk factors for a severe coronavirus infection, investigations and diagnosis of COVID-19 and some difficulties associated with this, and then common complications including respiratory failure, venous-thromboembolic disease, myocarditis, acute kidney injury and acute liver injury. Finally, we have touched on the use of dexamethasone.